So our next speaker is Professor Eline van der Beek. Eline is the head of the Nestlé Institute of Health Sciences at Nestlé Research in Lausanne, Switzerland. She holds a PhD in neurobiology from the Faculty of Medicine at Utrecht University and brings extensive experience with over 25 years of research in both academia but also in commercial environments. Eline is also professor for nutritional programming as an endowed chair at the University of Groningen. Her preclinical, epidemiological, and clinical research in molecular metabolism and nutrition aims to understand the role of nutrient quality and the contribution of maternal health and diet on the child development. She has published over 150 peer-reviewed research papers and is an inventor of over 25 patents. So Eline will share with us today really, how can we address effective specific nutritional needs, taking in the example of pregnancy and lactation. Over to you, Eline.
Very good. So first of all, thank you very much for this elaborate introduction. And indeed, I would like to share with you, I think, a bit more a specific example of what fits into what we would call the stratified domain, as just introduced by Sarah in the previous talk. If we think about nutrition during pregnancy and lactation, it's good to emphasize that we're talking about also how nutrition during the first 1,000 days influences maybe not only the health of the mother, but also that of the next generation. When we look at our risk of disease and we look at it from a life course perspective, it's very clear that the risk increases as we age, but we now know much better that a lot of that actually dates back to experiences that happen much earlier in life. So it's very interesting to try and better understand how what we actually eat and feed during this early life window can help for disease prevention, and then the nutrition status and the health of the mother is of particular importance. Unfortunately, we can say that for many women that enter pregnancy, their nutrition status might not be optimal. These are some data summarized by some recent publications that highlight micronutrient deficiencies that are quite prevalent in women of reproductive age, and they're related to adverse pregnancy outcomes. So we know that a large proportion of the women have 2 or more micronutrient deficiencies, and this is not restricted to low and middle income countries, but can also occur in higher income countries. And we know that the most prevalent micronutrient gaps go way beyond iron and folate. They have been part of fortification programs and supplementation programs in different countries around the world and extend into also zinc, vitamin A, iodine, vitamin B12, and vitamin D. There's short-term risks that are associated with the immediate pregnancy outcomes, both for the mother as well as for the child, which include really adverse pregnancy outcomes, but also, for instance, preterm birth or the size of the baby at birth, which will have consequences for the development after. And with that come longer-term adverse outcomes related to the altered growth that happens, especially when children are born small, early, or large, but also changes in the developmental path that can have impact for diseases, the risk for diseases that occur many years later. So not only do we have already notified these problems of women having multiple micronutrient deficiencies, actually if we look at pregnancy, it's also a very specific window in which there's additional nutrient needs. And this graph depicts the different micronutrient and energy and macronutrient needs that are associated with pregnancy. They're either for the adaptations on the side of the mother, or they're related to the development and growth of the placenta and the development and growth of the embryo and the fetus. And we also see that these increased nutrient needs are actually quite specific. They're not all across the board higher for every micronutrient or for energy and protein, but they're very specific related to the processes that are ongoing in the body. Not only do we have these higher nutrient needs, but also they may change over the course of pregnancy and lactation, related to the adaptations on the maternal side, as well as the development of the placenta, the embryo, and after the fetus. We also know that many women actually struggle to have a healthy diet. And of course, this is known worldwide, but there's some studies that depict to us how big actually the size of the problem is. So first of all, we know that in many countries, women struggle to have adequate weight gain during pregnancy, and we can debate for a very long time about the recommendations for adequate weight gain, but we recognize that there's countries around the world where women have excessive gestational weight gain that is associated with high birth weight, but also that there's countries around the world where there's a prevalence for limited gestational weight gain with an increased risk of small for gestational age as well as for preterm birth. There's an interesting study that was published a couple of years ago where they looked at the Australian guidelines, and Australia was one of the countries that very early on had recommendations specifically tailored for pregnant and lactating women, where they looked at not only what women ate, but also what their perception was about the healthiness of the diet. And that study actually showed that women actually didn't meet recommended intakes for instance, fruit, but also not for dairy. And that in the end, less than 10% of pregnant women met the main groups that are recommended for the diet for when women are pregnant. And this all happened in the context of that the women were making adjustments in the diet, thought that they were eating quite healthy, and some of the adjustments actually took them further away from the recommendations. So there's a lot, I think, that is misunderstood about the nutritional needs during pregnancy, but also what might be the dietary adaptations needed. And this comes on top of some of the prevalent micronutrient deficiencies that are depicted here in the table at the bottom of the graph. So we also engaged in our own studies, and I want to share with you this example of the Ming study that was conducted in China, where the nutrition status and dietary intake of Chinese pregnant women, lactating women, and actually also of infant and toddlers was assessed. And I share with you two graphs. On the left-hand side, the intake of specific food groups and how that differs from recommendations. And especially during lactation, you can see quite large deviations from the recommended intake if you just base it on the recommendations for different food groups. But when you drill down into the analytics and look at the levels of energy and nutrient intakes compared to daily recommended intakes, it's very clear that for not only macronutrients and total energy, but also for many micronutrients, women do not meet the recommended intakes. And for some of the nutrient intakes, women met less than 30% of the RNI, and this was true for energy, vitamin A, thiamine, riboflavin, vitamin C, calcium, iron, and zinc. So quite a number of nutrients. So what can we do about it? Well, first of all, there's different routes, I think, to solutions, especially if you talk about this group of pregnancy and lactating women, which is also, of course, a very determined period in a woman's life. So there's different ways, I think, in which we can improve nutritional intake and nutritional status. First of all, of course, it's important to pay attention to dietary diversity, but there's definitely also solutions where we could think about foods that provide the nutrients that are important during pregnancy and lactation in such a way that they fit into a diet and would enrich the intake of those nutrients of which we know there's many deficiencies around the globe. Last but not least, and I think the area where there's a lot more research ongoing also in the clinical space, of course there's supplementation. Because especially in the case of severe deficiency, but also in this case when we talk about such a specific target population, like pregnant women, of course it's very interesting to see what you could achieve by tailored and dedicated supplementation to this target population. So first, dietary recommendations. I want to share with you a piece of work that maybe we're not utilizing enough yet, but that's the digital support to help people understand what is a balanced diet, but to also give them some practical tools on how to make adjustments in the diet. Oh, and I think I've uploaded the presentation with the hidden slides. I'm going to skip this part. Yeah, sorry. You missed the dietary part. And if you're interested in what we've done in the machine learning and the algorithm development to learn more about how Nestlé is trying to support people to get their diet closer to recommendations and improve the healthy balance in the diet, I ask you to come back to me and ask a question. So I'm immediately going to deep dive into the supplementation route. we were happy to collaborate with the EpiGen Consortium to investigate supplementation with a multi-micronutrient that is actually based on review of the literature to see what could be an effective nutrient supplementation that might improve pregnancy outcomes. The selection of the nutrients was based on standard recommendations and those nutrients where we assumed we could achieve a benefit on pregnancy outcomes. The study was originally tailored to look at the risk of gestational diabetes. Here we did not achieve a positive effect, but it explains the myo-inositol in the supplement. But we obtained some very interesting effects that I'm going to share with you here today. What is interesting is that this supplementation started preconception. It started at least 6 weeks before women conceived, and it continued during pregnancy, and it was stopped at the moment that women gave birth. And I'm going to show you some of the outcomes related to this supplementation. So first of all, what we saw is that the intervention reduced the risk of major delivery complications. I want to specifically mention the reduction that we found in the incidence of preterm birth, a reduction by 57%. We also found a reduction in premature rupture of membranes and also of major postpartum hemorrhage in the women. In addition, it was clear that the supplementation that started in the preconception phase reduced the time to conception, but only in overweight women. There was no effect in women of normal weight, and there was actually a tendency for a longer period to conception for women that were obese. So there was a positive effect of the supplementation, but only for women with overweight. When we look at some of the outcomes in the children, now the first data start to emerge that it was not only pregnancy outcomes, but there might also be benefits for the offspring of trying to supplement the women before and during pregnancy with these crucial micronutrients. We saw that in the children there was a reduced risk of obesity, and in this case defined as the children above the 95th centile for BMI, and there was almost a 49% reduction in the offspring that was born from women that had taken the supplement. This was also illustrated by the reduction in fast growth, both when measured at 1 year of age as well as measured at 2 years of age. And these results were recently shared during the Lancet Summit, indicating how important it might be to supplement women during pregnancy with adequate micronutrients. But we also have to recognize, like was said in the previous talk, that these micronutrient supplementation may not mean the same for everyone. So first of all, I share with you on the left-hand side the example of vitamin D. So clearly, the micronutrient supplementation in the women that received the supplement increased plasma vitamin D levels, as you can see on the left-hand panel. But the supplementation stopped at birth, and what you can see from the 6-month analysis in plasma is that vitamin D levels returned to those found in women that received the control supplement. What was interesting, though, is that when the milk of these mothers was analyzed, vitamin D was consistently higher in the milk of women that actually received the supplement during pregnancy and the preconception period. But then when we drilled down into the different sites that contributed to the study, and I'm showing you here the results of the women that were included in Singapore and the women that were included in New Zealand, it's very clear that the improvement in vitamin D was not the same in Singapore as it was in New Zealand. And I think this indicates that we indeed need to, even in the case of a stratified population like pregnant women, need to consider potential differences in effectiveness of the supplementation. And I think a good way to think about this is really to say we need to think about supplementation, but we need to take into account the needs. Of course, addressing the evolving micronutrient needs during pregnancy and lactation requires a tailored approach. And even in the case of analyzing the results of the NIPPER study, I think it became quite clear that if you want to supplement women, you need to take the different phases of pregnancy into account. So we have developed a supplement based on these results, and this will actually be brought to market next year. But what I really would like to drill down to a little bit more deeper is that this variability that we can have with the supplementation is something that has been observed before, and it may actually be associated with the outcomes. And a good illustration of that is the ORIP study that has been conducted in Australia, led by Professor Maria Makridis. In the ORIP study, they used a high-dose omega-3 supplement that they gave to women with the aim to reduce preterm birth. This has been known from the literature. There's good meta-analysis, systematic reviews that show there's an association between omega-3 status and the risk of preterm birth. So they engaged into this very large study. But what they found is that women that had low baseline DHA levels actually benefited the most from the high-dose supplementation. And when this high-dose supplementation was given to women that were already replete at the start of the study, actually it increased the incidence of preterm birth, which definitely shows that more is not better, but also that we really need to think about how we can tailor our supplementation to the needs. Not only do we need to do that because we're interested in reducing the risk of preterm birth, but like in the case for vitamin D, we need to realize that the omega-3 status of women is also very important for the levels of omega-3 that later appear in the milk, because only part comes from the diet and a large part comes from the maternal stores. What we know from analysis in milk samples that have been collected in different studies around the globe, that there's a huge heterogeneity in how much women have levels of intake of omega-3 through their diet, and this is really translated into the levels of omega-3 in milk. And what you can see that is in mature milk, if we look at the global recommendations for omega-3 intake and how those should be reflected in milk, only 30% of the infants actually reach target levels of DHA when they're exclusively breastfed, which also illustrates that there's room for improvement on the maternal side. So how can we do this better? We've engaged with Maria to actually look better at the data and see if the data would allow us to come with a more tailored approach. So using a quick testing method, using a blood spot, the levels of omega-3 in blood and in milk can both be addressed. They can be applied to algorithms to actually sort out how women may benefit from a certain level of supplementation. And this can come with the recommendation of specific supplements that might already be on the market. I think this science-based proprietary algorithm development helps us to personalize the omega-3 doses that we can give to women either during pregnancy or during lactation. And we could do this based not only on the large data set coming from the ORIP study, but again, also utilizing the analysis of breast milk samples that have been collected around the globe in different Nestlé studies. So this algorithm has been developed and is currently being tested, again, in a clinical study in Australia by Maria Makridis, with different doses of DHA supplementation based on the baseline to see if we can improve outcomes for both mother and child. So I hope that with these different examples, I've shared with you the need for not only maybe thinking about personalization, but really to pay attention to the possibilities of stratification. We need to recognize that many women do not start pregnancy in good nutrition and health status. The prevalence of adverse maternal health is actually increasing. We know that the prevalence of maternal overweight and obesity before women become pregnant is becoming the more dominant adverse maternal health situation for many pregnancies around the globe. And we also know that there's many micronutrient deficiencies regardless of the type of diet, and that those micronutrient deficiencies are associated with adverse pregnancy outcomes. I think what the NIPPER study showed us, the study that has been conducted in collaboration with the EpiGen Consortium, is that pre-pregnancy is clearly a key window for opportunity, because we could address all forms of malnutrition, but knowing that 48% of women of childbearing age have one or more deficiency across the globe, this is maybe the moment to intervene. And we've also shown that pre-pregnancy supplementation can significantly reduce the incidence of adverse pregnancy outcomes. But we have to bear in mind that one size, even for this stratified population, may not fit all. Many of the micronutrient needs change over the course of pregnancy and over the course of lactation, which requires maybe a more tailored approach already when we think about the different physiological stages that happen during pregnancy and lactation. But we also need to recognize that we need to think about baseline measures, because taking into account baseline measures and the risk that may come with excess intake may help to address individual needs more adequately, as we've shown in the last example. And with that, I thank you very much for your attention.